Professor Nessrin, you finished your comment, or should I carry on, or should do you have anything else to add?
I don't remember where we stopped with you, Dr. Nikofar, but I was answering a question about how we could encourage high recall rates.
Okay. You finish your answer. If you want to carry on talking about that, please carry on.
If Hugo's happy, I think I'm happy. Proceed.
Okay then.
I'm happy. Thank you.
All right then. So let's go back to the procedure that we talk about it and the appraisal. So the question is, does the study provide a clear explanation of how participants were randomized? As Dr. Nessrin mentioned, there is a limitation sometimes for the number of the words for the publication. So they couldn't actually provide sometimes every details of the randomization technique. But to be honest with you, this study is one of the studies that they clearly explain everything about the randomization technique. And the randomization was block randomization technique to allocate each tooth to either partial or full pulpotomy, and then try to use this methodology to make sure that they actually distribute the enough numbers of the cases to each block and make sure that all the variables have similar effect on the outcome. So the consult allocation also was, as Nessrin mentioned, has done by her. So the operator was blind about that one as well, because a research assistant actually helped this assignment, if I get it right. And then, so the question now, Nessrin, as I think you already mentioned some part of that, is could you elaborate on the specific methodology that you used to generate the randomization sequence? Because it was the part that you didn't mention in the article, or at least I couldn't find it. Was it computer generated, and how did you ensure that the sequence was truly random? Because I couldn't find it in the article.
I think it's from the definition, Dr. Nikofar, and you know more than me that block randomization cannot be performed manually. It has to be online on a computer generation, where you enter how many procedures you are looking at. For example, we assign letter A for partial pulpotomy, B for full pulpotomy, and then you choose the size of the block, 4 or 6 or 8. Then the computer comes out with the sequence for you in blocks of 8. For example, one block will come AA, B, B, E, A. So you cannot guess it actually or predict what's gonna be the next tooth. So it provides you, it's ready by the computer on an Excel sheet.
Correct.
And then you take and put in an envelope.
And then the next question is about the block size justification. Because when we choose the number 8, actually, we need to make sure that we actually distribute them in a proper way and cover all the possibility of the outcome. Is there any reason for this number 8 or not? Can you describe a bit more?
It was the maximum that was offered by the statistician, and it will provide the best randomization. If you go to block of 4, the randomization is weaker, and the operator may somehow could predict what's the next sequence. But with the block of 8, it's not an easy thing to predict.
And
so
the
it
next
eliminates more.
Can help you as well, because with this number, you already actually covered age, sex, and tooth characteristics in each block, actually, which is also one of the very, very, very powerful part of this study, to be honest with all of you. So when I tried actually to be picky and find something to ask question from Nessrin, I couldn't find it in this part. Usually studies, they have a lot of problem in this part, and they covered this part very well, and therefore it was very good. And I already asked about the blindness of the operator, and Nessrin mentioned that they tried their best actually to make it more blind to all part of that, except the part that the operator worked. But I want to ask you another question. the supervisor, because usually when one of our postgraduate works, they have supervisor. Have you tried actually to make the supervisor blind about the performance or not? Because sometimes maybe if you like, or the supervisor likes to have a better result for full pulpotomy, they may keep an eye on the student or postgraduate student, and when they don't want actually to get a good result from the other one, they may ignore the mistake, something like that. Can you describe how do you manage this part?
For research cases, Shuruq, the graduate student, she did not have supervisor because I did the calibration for her during the first year. So I was looking at every vital pulp therapy case she performs. But for the research cases, she's not allowed to ask help from supervision, other supervisor on the floor. And she would come extra days, actually, outside her clinical course days, because she has like 1 or 1.5 days research days for looking at these cases.
Very good.
So
very
she
good.
did not receive any advice.
Very good. Very good. So also, I have a question about the depth of the removal of the pulp tissue. When you mentioned 2 to 3 millimeter removal of the pulp tissue. So the question is that it can be another inconsistency in the variable, because sometimes you may remove 2, you may remove 3 millimeters, less or more, it may have some effect, because the remainder of the pulp based on the volume of the pulp chamber can be different. And also the removal may have some effect. You don't know actually, do you remove enough contaminated pulp or not? What do you think?
Yes, we followed the conventional definition for partial pulpotomy by Schweck, which is the 2 to 3 millimeters. How would we maximize consistency for this volume? It's by referring to the burr. We usually use a long diamond burr for cutting the pulp tissue. So the operator would observe how deep the burr is inside. I know she's not computerized, the operator. There might be some inconsistency in the size, but I assume it's minimal, like it will not go beyond 4 millimeters like a large. So partial pulpotomy was definite, and you could see, if you look at the radiographs in the figures, you could see some variations sometimes, but it's mostly in the coronal direction, which depends on the depth of how far the pulp chamber is. We did not attempt any removal beyond 2 to 3 millimeters, because otherwise it will introduce bias, as you said, because it's more than a partial pulpotomy. In real life practice, what we follow now at our postgrad clinic, we remove 2 to 3 millimeters. We try to achieve hemostasis. If there is no hemostasis, we do not go to full pulpotomy actually. We attempt another removal of 2 millimeters and reassess again. In case of 2 removals, we fail to achieve hemostasis, then we go to full pulpotomy. This is exactly minimally invasive endodontics. But for reliability of comparison between partial and full pulpotomy, we had to be strict with the removal of 2 to 3.
Perfect. Perfect. Thank you very much. That's great. Okay, so let's quickly look at the results because of the time. We have 200 tests from 151 subjects, 87 males, 113 females. And when we look at the age, and also we can look at other baseline characteristics, there was no significant difference in baseline characteristic between full pulpotomy and partial pulpotomy groups, thanks to the block and 8 blocks and whatever that we already discussed. When we look at the pain levels, yes, go ahead. Nessrin,
yes, I may go back to one question you wrote, Dr. Nikofar, in a couple of slides before. When you asked me, did you balance the preoperative baseline variables? But I did not answer that question. Actually, I cannot balance it because it's a randomization. If we get more female,
you already did. The good thing is you already did. As I said, thanks to the randomization technique, you already covered this important part.
So it's randomization, and luckily that randomization was effective, because when we did the statistical analysis, there was no difference in the baseline variables, which strengthens our results.
Yes, That's great. That's great. I think our participants also noticed that you didn't do anything for this part, but because of the number of cases that already one of our colleagues mentioned that, and because of the technique of the randomization, which was very precise, as you can see here, no significant difference was observed for these baseline characteristics. Thank you very much again. So pain, preoperative pain, and also post-operative pain in both groups also evaluated. But again, preoperative pain, as all of us know, has direct effect on the outcome. So there were, again, no significant difference between preoperative pain levels between the groups. So this is another issue that I think because of a good randomization happened. But when we look at the post-operative pain, significant reduction in the pain levels in both groups after 1 week has been seen. 98% of subjects reported relief from pain or mild pain and were satisfied with the treatment. So you can see that in this diagram. And when we look at the outcome after 6 months, success rate for full pulpotomy, it was 1 failure. Partial pulpotomy was 6 failure. Full pulpotomy had a significantly higher success rate rather than partial pulpotomy at 6 months. Then when it goes to overall result at 12 months, again, the significant difference in success rate between full and partial pulpotomy was observed, which is also important for the result and talking about the result. So effective variables on outcome also measure factors influencing success. I think this is the most important clinical part of the study. Factors influencing is actually showed in the result, and it shows that the hemostasis as well as the patient age, they have actually key factors that identify by the research. And the type of pulpotomy. Full pulpotomy had 14 times higher odds of success than partial pulpotomy. And older patient had lower success rate. And hemostasis has the most important effect, which was in accordance with the previous studies that showed that higher success rate, particularly in partial pulpotomy, was related to the duration and time of the hemostasis, which is very, very important. But now I want to ask Dr. Nessrin another question, which is about the influence of patient age, because the results suggest that the older patient had lower success rate for partial pulpotomy. Do you think it has some effect on the clinical guidelines when we want to choose the treatment modalities?
Yes, of course, Dr. Nakufar. With partial pulpotomy, as you know, and you mentioned, we removed only 2 to 3 millimeters. So there is a chance that some infected tissue is still there. So when the patient is young, there is higher vascularity in the pulp chamber of young teeth, higher number of cells, of stem cells. So it seems that there is higher chance for confining this infection and driving healing more than in an adult pulp tissue, which has lower cellularity, lower vascularity. And actually, this is the first study in my trials that showed this effect. Because with our previous study on partial pulpotomy, we included only adults above 20. But in this case, we had from 11 to 2 or 63, I think. So we got this effect for partial pulpotomy. But for full pulpotomy, there was no effect because we are removing more of the pulp tissue. So we are maximizing the chance for full removal of infected tissue.
Okay, so it goes to the next question now. So when we go to the next question, when we want to choose partial or full pulpotomy, so how do you explain that according to the result of your study?
The difference in success rate because we included cases with severe symptoms, and it's only spontaneous, moderate to severe. So we took it to the extreme, very deep caries exposing the pulp, symptoms are high. So there is a chance that if you remove only 2 to 3 millimeters, you are not removing enough of the infected tissue. So you may consider these factors: severity of symptoms, age of the patient. You may consider removal more than 2 to 3 millimeters or going to full pulpotomy for more predictable outcome.
Okay, and please go ahead and talk about the time of the hemostasis and the effect of that.
Yes, for time of hemostasis, my previous clinical trial, I looked at time of hemostasis and all the factors, and we never had any evidence that it's important, except in this study, which I think related to the large sample size, because our calculation was actually gave us the need for 70 per 70, and we were successful in recruiting more patients. So it was 100 versus 100. So the sample size had a good power, which showed this difference. For full pulpotomy, it did not make a difference because of the very high success rate, only one failure out of 100 cases. But for partial pulpotomy, I think 15 out of 17 failures were required 6 or 8 minutes. So we recommended in that article, if you cannot achieve hemostasis in 4 minutes after removal of 2 millimeters, then attempt another 2 millimeters of tissue, or if you don't want to waste your time and do further judgment, just go to full pulpotomy for more predictable success. But if you decide to take the risk of 8 millimeter hemostasis, then you have to know that your success rate will be in the 80s rather than the 90s.
Perfect. Thank you very much. Is there any question from our participants? Is there any comment, any question, anything that you want to add? Because now it is time that, yes, Vijay Kumar, please go ahead. Please introduce yourself and ask your question or add your comment. Go ahead, please.
Thank you, Professor Nicofa. It's a privilege to hear this journal club, and I'm here on behalf of Professor Ajay Logani from India. Yes. And I can see the great legends of vital bulb therapy here, Professor Taha, Professor Imad. Professor Taha, I have a question that in the part of hemostasis, you mentioned that you have used 4 minutes as cutoff time for partial pulpotomy, and in the methodology, it is 2 minutes application of the cotton pallet, moisture cotton pallet. So, what is the rationale behind using it every 2 minutes? Like, shouldn't we be using it 4 minutes because the normal clotting time is that much? Or are we not disturbing the clot when we are checking it every 2 minutes after removing the cotton pellet?
No, I don't think we are disturbing the clot, because in many of our clinical trials, we could achieve hemostasis in 2 minutes. And I think sometimes the operator, you need to see, the pulp is still bleeding. Plus, sodium hypochlorite might be depleted if you leave it for a longer time. So I like to apply fresh sodium hypochlorite every time. And we still have a number of cases where hemostasis could be achieved in 2 minutes, actually. So it's clinical time. Clinical time is money. And, you know, if you can. One of the advantages of vital pulp therapy in terms of cost effectiveness, that it's a shorter clinical procedures compared to RCT. So every minute will count.
Thank you. Thank you. Any more question, Vijay? Do you have any more question? Okay. Dr. Sohrabi, please go ahead.
Hello, everyone, again. This is Dr. Sohrabi. I'm working in Tehran University as associate professor. One of Dr. Professor Nekufar, more than 40 years, friends of him. Let's say, without consuming any extra time, at first, appreciation, Dr. Nekufar, for reloading these useful appraise to raise programs. I have a question from Professor Taha. Professor Taha, excuse me, do you have any suggestion or do you find any study about the correlation between the histologically, I mean, the depth of the partial pulpotomy, you mean 2 to 3 millimeter, and histologically the extension of the inflammation of the inflammatory cells of the necrotic tissue into the pulp tissue. Do you have any suggestion? Did you find any correlation? Yeah, I mean, do you find any study between these two practically? I mean, death of pulpotomy, death of the action, and histologically, the extension of the microorganisms and inflammation into the root canal system, I mean.
Dr. Nessrin, before you answer this question, I want to ask Professor Imad to talk about it a little and then ask you to add to it, because I know Dr. Imad covered this particular question a lot of time. Dr. Imad, please, Professor. Oh, please unmute yourself.
Yeah, so the comment you want is about the histology of the pulp? Yeah, so
Yes.
maybe I will make a kind of general comment. Probably I will disturb some of you because I will not use the same vocabulary and I will do it on my way.
Okay.
So the first point I wanted to highlight, and this is just to bother the endodontist that you are, is that you always talk about the depth, how much you remove and what is the depth. To me, the most important point between the difference between full pulpotomy and partial pulpotomy is the surface area that you will treat on which you will put the material. You have never heard this before, and that in a big part explains the success rate between full pulpotomy and partial pulpotomy. Full pulpotomy, you hardly have any surface. You have very little interaction. You have no problem. In partial pulpotomy, it can be whatever it is, big, small. What is important is the length of the line that you are treating. As far as this is big, this is important, and that correlates to every single aspect. That correlates to the material you apply and the interaction with the material. That correlates with the bleeding time, because the highest the surface area, the more bleeding you have, and even when you control it, you still have some leakage of liquid, and that will alter the material that you apply. And I would say, so that I see the faces that apparently you agree somehow. And there are two other factors I would like to include. From your calculation, you always forget the patient. And we are people who did a lot about the pulp capacity to withstand stress and to resist bacterial infection and to inflammation. And you can believe it, we have done a lot of publications demonstrating that the pulp has the capacity to withstand stress, to resist inflammation, and even to produce molecules that we call the complement molecules that can literally kill bacteria. So even if you have still some bacteria remaining in the pulp can kill these bacteria. Then in the past, long time ago, we did a very big number of studies on the factors that influence the successful treatment in restorative dentistry. And clearly it appears that the presence of bacteria is the factor number one. So what you need is to eliminate bacteria. That means prevent leakage. And if you want to prevent leakage, that means the choice of the material is also very important. The last point I would like to focus on is that when you use a material, when you apply it on the pulp or any other tissue, the successful outcome is the outcome of the interaction of the two. Not only the material, not only the tissue, but when you put the material on the tissue, the result is different depending on the material. And we have demonstrated that some materials, for example, can have anti-inflammatory activities that appears after the clinical studies that, for example, Professor Taha has conducted, where when you apply this type of materials, the patient comes with pain, with severe lingering pain, as you mentioned. And after the treatment, pain disappears because you reduce the migration of inflammatory cells to the pulp. And as you know, all of you, the pulp is an inextensible environment. So it is a rigid environment, and when you have an inflammation, you have pain. If you decrease the number of migrating cells, the diameter of vessels, you decrease pain. So basically, there are many elements that we don't take into consideration. I hope with this that we'll try to change the vocabulary used in the depth of the cavity, because for me, it means nothing. It is a depth of an injury. The pulp is a tissue like any other tissue. You don't need to treat it in a different way. So don't behave as if it is a specific tissue, too particular. Yes, it is particular in the sense that it is within an inextensible environment. That is true. And for this purpose, it has a big capacity to withstand stress. This is true. But for the other aspects, it's just a tissue like another. When it bleeds, it's normal, it's viable. If it doesn't bleed, you should ask questions.
Amazing. Thank you very much. Thank you very much.
My pleasure.
Very comprehensive. Amazing, as usual. Hesam, please go ahead. You have a comment. Please introduce yourself and go ahead.
Hi everyone. First of all, thanks for this clinical study, and also thank Dr. Nekufar. I had a question about hemostasis. By the hemostasis, do you mean a complete bleeding stop or a control situation to place the biomaterial? Because a complete bleeding stop is usually difficult to achieve, especially in a symptomatic pulpitis. So this is my first question, actually.
Okay. If you want me to answer, yes, we always aim in our studies. I'm talking, it's different what I do in the clinic for my patients, but in the studies, we always aim for complete stop, except a very minor ooze. But if we think that this is minor oozing and then you place the material, calcium silicate material, and you find it's contaminated with the blood because the pulp continued to bleed, then no, we exclude the case and we consider it inability to achieve hemostasis. Because you have to be strict when you are doing a clinical trial. But in the clinic, sometimes I say, oh, I will see, I think only the mesiobuccal is oozing a little bit, maybe with the pressure of the bulk of calcium silicate, I will achieve hemostasis. So sometimes I try it on patients, sometimes I am successful, sometimes it's a failure. But with the clinical trials, we aim for complete hemostasis.
Complete, okay. And the other question I had is about the dilemma for doing partial pulpotomy. So imagine when at the place we enter the pulpa, we have bleeding, so we can decide for partial pulpotomy. But yeah, in some cases we have a partial necrosis. Perhaps one of the root canal is necrotic, while we have bleeding at the place we already entered the pulp. So how we can make sure that there is no necrotic tissue?
You cannot actually be sure. It's a predictable, it's a guess. You removed 2 to 3 millimeters, you observe that part that you exposed under magnification, and you make a guess that it's a healthy tissue based on the appearance, the color, the ability to achieve hemostasis. And we are not 100% correct in our guess. That's why we get success rate of 85 in partial pulpotomy. So it's a guess.
That can be another reason that we can recommend, based on your article, recommend to do full pulpotomy. The explanation that Hesam mentioned, that because we are not sure about the other root canals and the situation of the vitality of the pulp in other root canals, maybe it's better to do full pulpotomy to evaluate the orifice of other canals as well. Do you agree with this comment that Hesam mentioned?
I don't actually prefer to recommend full pulpotomy all the time, Dr. Nekufar. For beginners in vital pulp therapy, I do recommend full pulpotomy in symptomatic and in mild symptoms even, until they feel confident in evaluating hemostasis and the appearance of the pulp. Then after that, you will develop an internal feeling that you will love the pulp more, and you will feel that I can save more of this vital tissue, I can be more minimally invasive, and you will be more trained in vital pulp therapy, then you start shift back. Other factors may intervene now, like when I have kids, even with severe pain. I like to save more of the pulp tissue because it will enhance further dentine deposition in a young tooth, which will strengthen the tooth. So I always attempt partial pulpotomy in young kids. Remove 2 millimeters, not successful, I go to 4 millimeters. I may go back to comment on Dr. Imad. Excellent explanation. It can be further supported if the audience, I'm sure they have read Ricucci studies 2014, 2019. There is no clear cut-off point histologically for the extent of infection and tissue destruction for teeth with similar clinical presentation. You will have patients with spontaneous pulpitis, but when you look histologically, some teeth, they are infection and bacteria is in the first 2 millimeters, other teeth, it's expanding more to 4 millimeters. So when you do partial pulpotomy, you are making a guess about that you have removed the probably infected, but you will be more confident if you go to the full pulpotomy. Now we are doing a histological study looking at this, and hopefully we either confirm Ricucci finding or we can come with another finding, who knows, but we have not got our results yet.
Perfect, perfect. So I think we almost now discuss around 90 minutes. So I want actually to move a bit quicker because of the time. So we already covered these things from the discussion. So I jumped from this slides because we already covered the influence of patient age and clinical implications and also recommendations. In discussion, everything of that is covered. Also the future studies, I think Nessrin has already talked about the future studies as well, which is also covered in the publication. Again, I want to thank everybody for participating, and also thanks a lot from Dr. Hugo, actually, let's say both Dr. Hugos, two Hugos are behind the scene for this amazing gathering. Thanks a lot. Because of your energy, we are now talking around 90 minutes about this amazing publication. And actually, this is also Professor Dr. Hugo Plastentia, if I correctly pronounce his name. So I think it was his recommendation to choose Nessrin for the first session, and I'm very happy for this. But now I want to ask a very difficult question from everybody. So, and also from Nessrin as well. Obviously, if anybody can have some quick comments about that, considering the delicate balance between preserving natural tooth vitality through pulpotomy and ensuring long-term success, similar to root canal therapy, how do you envision the future of vital pulp therapy evolving with advancement in regenerative endodontics? I'm sure Dr. About is going to give us a lot of things of that. Could there be a paradigm shift where the goal is not just to treat pulpitis, but to regenerate the pulp tissue itself, potentially making pulpotomy an even more favorable option? So this is the question that I think all of us should think about it. And we are going to end up our session by receiving comments about that from most of you. Nessrin, you go ahead.
Regeneration more, I think this is more into Imad's field. I did my best. If he suggests that I place growth factors or leave a space, because the pulp already is rich in stem cells. What do you want us to add more? Calcium silicate material, it stimulates the release of growth factors from dentine. It also activates complement systems. So my knowledge is limited in this field. I'm currently interested in inflammatory.
To be honest with you, you did a great job because you actually choose a tissue which is available for all of us before applying regenerative stuff, which is very sophisticated treatment. You did actually, you make it simple for everybody to do this procedure, and for the student, even for the people that they cannot afford the treatment. This is amazing. Congratulations to you. But on the other hand, I prefer to say vital pulp treatment is a type of controlled regeneration, if Imad is agree with me. But I want to ask Hugo actually also to add something to that. And also I want to ask Talal, because I know Talal always said that the best filling material is pulp. In all of his lecture, he preferred to say such a thing. Hugo, please go ahead.
Yes, thank you. Again,
Hugo,
Hugo
please,
Plasencia from
first of all,
Mexico.
Hugo, please help us with how to pronounce your surname first. We want to practice that.
Hugo Plasencia. Plasencia. It's
Placencia.
difficult. It's difficult.
Okay, please accept my apology. Professor Placencia. Oh, see, again, I couldn't.
Great. Great.
Okay,
Thank you.
please go ahead. Please go ahead.
One last question. Professor Taha, about the pool canal obliteration was not reported in TIT manuscript. About some manuscript says pool canal obliteration is success, and other manuscript pool canal obliteration is failure. What is your opinion? In this manuscript is not reported.
I don't think that you can evaluate pulp canal obliteration from a 2D radiograph, Hugo. I'm not sure if you were with us at the start of the discussion when I mentioned that I started taking CBCTs for cases that appear to be narrowed or obliterated on digital radiographs, and I found the canal was patent. So it's not actually a common complication after vital pulp therapy. It's completely different from regenerative procedures and revitalization. So it's not a complication. And sometimes when I take 6 months follow-up, I see the canal narrowing. When I take 1 year follow-up, the canal is there. So it's related to the angulation of the 2D. We need studies with 3D evaluation to report on narrowing or obliteration before we can set it as a definite complication for vital pulp therapy. But even if the canal is obliterated, if that tooth is having a crown, what's the problem with canal obliteration? It's denty, it's a hard tissue. If it's not infected, it will not cause symptoms, tooth is properly restored, I don't think it's a real complication. You may not agree, but this is my...
I agree. Totally agree. Thank you.
Thank you.
Well, now I'm muted. Maybe I can give my comment if you can hear me.
Professor Imad, yes, we can hear you, but I want you actually to close the session. So before you are going to give us your comment, I want to ask others to talk, and then you are going to be the last. Professor Talal. Please unmute yourself.
Okay, that's ma'am. Okay, I hope that you hear me now.
Yes,
I want to
very well.
Yes, very good. Very good. Really very nice work by Professor Nessrin, and this is something not strange actually. We enjoyed every minute of this discussion. On the other hand, actually, I want to emphasize that the vital pulp therapy is a really sensitive procedure. Like generalizing, I hope that I believe what our future expectation that vital pulp therapy will be practiced more and more, but this is on the other hand, we need to pay more concern actually about how it will be practiced when you generalize that you have like the symptoms, and please go ahead if you have this symptomatic pulpitis, do pulpotomy. We need to understand or to emphasize for our practitioner that they need to have a microscope. They need to see actually the tissue, because sometimes you will be controlling the bleeding, but when you look under a microscope you will find a lot of dentin chips covering over the pulp. So this sometimes will influence the direct contact between the regenerative materials you are going to apply, and then for sure it will affect the outcome. So this is one of my concerns. I believe future is going more and more for vital pulp therapy, but we need to understand that the practicing of this has to be really understood. And I was very happy that Professor Nessrin asked her student, I believe Dr. Shuruq, to practice for 1 year. So she were very sure of her way of practicing before launching the research. If we are not emphasizing and if we are not focusing for our practitioner about the accuracy and how important to pay attention to all details, actually we are ending up with catastrophic results. And on the other hand, we need to understand paying more attention on doing pulpotomy will especially if we incorporated this for undergraduate, and our students will take it more easy and easy. They will lose their let's say excellency and in doing root canal treatment. They will not have good experience when this case will fail to manage them. So I believe it is something very critical. I hope parallel. My message is whenever we are emphasizing on the vital bulb therapy, we need also to be in a parallel way emphasizing on whom is eligible to do the vital bulb therapy. This is something very important.
Thank you. Any other comments? Dr. Hugo Munoz, are you going to? Okay, yes, go ahead.
Is it me?
Thank you. I just want to say congratulations to Dr. Taha, amazing work. We know that making research is very difficult. Making a randomized controlled clinical trial is even more difficult. And publishing it is a lot more difficult. So, and I really appreciate your work and your willingness to be here with us, because being there, just hearing how do
Especially if you get
we
Nikuchi as a
praise and
reviewer.
criticize the work, it's another level. So I am very honored to have you here to this inaugural session of our journal club in SELA, and hope to see you many times more. So, and also Dr. Nekofar, thank you for the effort.
Thank you.
And
thank you very much.
your
Gisela,
willingness. Thank you.
you go ahead, please.
Thank you, Dr. Nekofar, to be possible to have this wonderful session. Thank you, Dr. Taha, for sharing your expertise with us and all this important information. Thank you, everybody, to be here, and we hope that we see very soon in the next session.
Thank you. But before we closing the session, we are going actually to have Nessrin to have her final talk. After that, Dr. Professor Imad About, who is the world authority in this field, is going to close the session. And we have a certification, obviously a virtual certification for Nessrin that we are going to share on the screen. Then I ask everybody to put their hand together for Nessrin at that time. And finally, we are going to take a group photo. So whoever wants to be in this photo, please turn on the video from now. Nessrin, please.
Thank you, Dr. Nekofar. I just want to provide a short comment, reply to Dr. Talal. I understand his concern, but this was actually one of the aspects that I explored, because my students who participated in the clinical trials over the past 15 years, they were of different clinical skills. Some of them were topic class, others were average, and I have included one non-experienced, I will call her non-experienced graduate student that was calibrated only on probably 5 cases, and she could achieve high success rates for full pulpotomy, particularly in the 90s, which was comparable to the RCT. So I believe teaching BPT has a short learning curve. If you just explain, demonstrate, supervise a couple of cases, you find it's very easily accepted by the practitioners with a good success. I'm talking about full pulpotomy, but for partial pulpotomy and pulp capping, it definitely needs an armamentarium, magnification, isolation, and an experience in evaluation of the appearance.
Thank you very much indeed. And it's actually worth mentioning that in behind some of the names, we have more than one participant. So I want to ask actually a group that I can see the name Jamie Barragan there, if they want to add any comment. Thank you very much. It seems that you and your student are listening to us. So if you want to add anything, please go ahead. And also we have people from early morning until midnight, people from Australia. Now it is actually the next day for them. This is amazing that we have all the people from around the world gathering for transferring knowledge. And obviously it is too much because of the name of Professor Nessrin Taha And we all actually admire her for her amazing job and amazing gifts to the knowledge. Professor Imad Abouts, the stage is yours.
Well, thank you very much. I will have to raise two aspects, the pessimistic and the optimistic. The pessimistic is that we lack diagnosis methods. Our methods are not perfect. They're not perfect in reversible pulpitis diagnosis. There's no link between bleeding and the pulp state. There's no link between the pulp state histology and the degree of inflammation. We cannot measure the depth of the dentine cavity. We do not measure to which length we can go. We cannot measure even the depth of the pulp cavity in case of partial pulpotomy. So this is the pessimistic, and these are ways that we need to improve. The second that is not yet the optimistic, but this is a thankful word to Nessrin Taha. I think I was one of the first who discovered her ability and how brilliant she was to bring an innovation in irreversible pulpitis treatment. And probably, Nessrin, you can correct me if I make a mistake. I think I was one of the first, if not the first, who invited you to an international conference. I believed in your capacity since the first minute, and I knew that you were doing an excellent job, and you were not the only one. There was another person, at least from the host country of this meeting, from Iran. That was Professor Saeed Asghari, who was doing this even earlier. And to me, that was an innovation in the field. Bringing a new therapy is really something very good. And given the fact that we had lacks in the diagnosis methods, that means plenty of vital pulp therapy were missing. Some of the teeth were missed just because we couldn't imagine even treating the teeth with vital pulp therapy because it was irreversible pulpitis, just pulpectomy, remove it, and it was lost, and you cannot get it back again. Now, the optimistic part comes from research. And you know, we have been doing a lot of research with the idea of developing materials. You all know biodentine that has been developed here. And our knowledge on the complement activation and its implication, not only in the inflammation, but also in the regeneration, led us to consider the following. In case of, you know that in case of direct pulp capping, you apply the material, you compensate the missed volume of the pulp, you apply the material, and then you get a tertiary dentin that forms at the expense of the pulp. If you look at this in 2D, it's a loss of a part of the pulp. If you look in 3D, it's a big mass of the pulp. If you consider the same thing in case of partial pulpotomy, it is a big volume that is lost. And when you produce the tertiary dentin, a big part of the pulp is lost. Now, if you go further with full pulpotomy, all the coronal pulp is removed. And then when you get regeneration, you get again the regeneration at the expense of the pulp. So from our knowledge on the complement, we developed kind of material in which we can include particles containing one of the complement factors called C5a. So when we incorporate this factor in the sponge, this factor is known to guide the migration of stem cells, the cells that produce the dentin. It guides their migration and it induces its differentiation. So we place this factor in capsules. We make an orientation of the capsule with colors in such a way that the dentist can see where is the capsules, where he should put it and which side. And once this is placed, the stem cells will migrate and they will resorb the material that we placed, and the dentin will be produced at the limit of the dentin and enamel, reproducing the whole pulp volume. Of course, if you wonder what you would put on the surface, a material that does not allow leakage, like calcium silicate material. So this is what we have done. And just for your information, this is the application in dentistry to regenerate the full pulp volume, but we also will use it in regenerating the bone because its receptor is expressed in bone cells, in the mesenchymal stem cells of bone. But also I have currently a student working on the regeneration of a spinal cord. In case of spinal cord injury, we know that the spinal cord does not regenerate in case you have an injury, but we know that the neurons express the receptor of this molecule, and when we apply it, the neurons grow, and we are hoping to get regeneration. So here, first paper is ready in vitro. We are doing this currently in vivo. So you see that we can apply our knowledge from dentistry for the improvement of the oral health of the patients in the dental field, but not only the dental field, because we have the application in bone for the dentistry, but also for orthopedics. We have this type of application again for in neurodegenerative diseases, but also for the skin regeneration. I'm talking to you about this now because it has been patented 1 or 2 years ago. So that means we can communicate about it, and it's published in the States, in Europe, in India, in Mexico, and currently in China. So I hope with this optimistic note, everyone feels happy, as we are happy with it. I would like to thank Dr. Nikufar really for this initiative. It is amazing. He is always innovating. I was really surprised because I heard about him being a student in England, and all of a sudden he is like a real leader in this field and a real initiator of many initiatives, which is of a great value for everyone, I think. I only regret that I could not attend many of these meetings, and I'm happy to be with you today. So thank you, Dr. Nikufar, again.
Thank you very much. So now be ready to thanks and put our hand together for Professor Nessrin Taha. Thank you very much, Nessrin. Vijay, please go ahead. If you want to add anything, please go ahead. Nessrin, thank you very much. I don't have enough word. I know you are very busy, so you dedicated 2 hours of your time. And surprisingly, I think for your appreciation, we have Professor Imad and all the participants to show their appreciation to you as a fantastic person. You are a fantastic person. More than a scientist, you are an amazing person.
Thank you. Thank you, Dr. Nikufar. Thank you, Dr. Imad. You are both like my brothers, and you know how much I love you both. I thank you for the invitation, and I thank everyone who attended the discussion, and I thank your interest, and hopefully in 10 years, inshallah, we will see vital pulp therapy more and more advanced as a specialty. We still do good endo, and many of my students and colleagues are attending this presentation, and they know that we could remove fractured instruments, we could obturate canals, but our main priority first is to save the pulp if possible. Thank you. Thank you once again.
Thank you very much, everybody. If any comment, anything that anybody wants to add, please go ahead. I think one of our colleagues, Tatiana, wants to add something. Tatiana, please unmute yourself.
Maybe Shukranat, you should authorize her.
Yeah, I did.
I got it. Yes. Thank you.
Please,
I'm really happy to be here, a part of this. It's my first time. I want to just congratulate all of you, especially Dr. Taha. You're amazing. Your research is unbelievable. It's helping us a lot. And I agree what, here Dr. Abud has said, we need to preserve the pulp. We need to continue the education. It's the way we need to start from our schools. We need to spread the word because there is there is a good chance to help our dentists, general dentists, pediatric dentists, and that's the way to start. We need to start with education, and then it's possible to preserve the pulp. It's the best way to go. And I know diagnosis is the key, but is the most unreliable portion that we have. Thank you. Thank you, everybody. It's amazing group, and it's amazing how much we are learning all together. I really appreciate all the efforts done. Thank you so much.
Thank you very much indeed. And hopefully we see each other in a month. So we will advertise again the next sessions. And thank you, all of you. And in the chat box, Nessrin, there are a lot of appreciation. We don't have time to go ahead for that. We actually start 2 hours ago, and now we are going to finish, hopefully on time, at 2 hours. So we are going actually to take a group photo now. So my colleague Zohra is going to take this group photo by some of the special application that they have. So maybe we just say goodbye to each other when we're taking this group photo. Goodbye, everybody. Have a very nice time and very nice weekend for some of you that you have weekend tomorrow, and others for Saturday and Sunday. Go ahead and take care of yourself. See you in a month.
See ya. Thank you.